the show where we describe to you guys all the new, greatest and latest in fertility and answer all your questions live. And tonight we have no latest and greatest to tell you about. So we're just going to answer your questions live. There have not been a lot of great studies out recently, and certainly nothing earth-shattering that I wanted to share with you all. There was one recent one that I put up in a post about day 5 versus day 6 embryos. Great feedback on that one, so thank you. And if you haven't seen it, just check it out on Instagram. But nothing else really exciting or new so far. So maybe next week we'll have better selection of studies to go over. So we're going to open the floor up to questions.
Hi, Dr. V. What can high cortisol level 648 nanomoles per liter signify? Additional testing one should do? How to lower it?
Well, it depends on what's wrong, but you'd need endocrinologic testing if your cortisol levels are persistently high. But it depends on what's wrong. If you're stressed, if you're sick, your cortisol levels will go up. If you've got sudden weight shifts, it can go up or down. If you have certain steroid producing syndromes, then that can definitely do it as well. So you do need further testing by an endocrinologist to figure that out, plus repeat testing and then, suppression testing. So definitely see an endocrinologist or a reproductive endocrinologist, because it can come from pathology. It can come from a variety of different things. So it needs to be thoroughly worked out. It's much more complicated than just the simple stuff we deal with from day to day. Excuse me.
Hi, Dr. Victory. I was diagnosed with a slightly elevated NK cells and a complete HLA-DQ alpha match with my partner.
Right.
The doctor from Fertility recommended a combination of immunotherapy, including
LIT.
LIT, right?
Yeah.
I had my consult with the facility in Toronto who performs LIT, and the doctor seemed concerned doing LIT since I don't have a history of failed implantations or miscarriages. Testing was done as a precaution. Do you see any harm in still doing the LIT? Is it better to be safe than sorry?
So there's probably no harm other than financial. It's very expensive. I think the bigger question would be, what is the benefit to doing it if you haven't proven that you've had a problem? So for me, that's easy. If you have like more than 3 embryos, I wouldn't worry about it, and I would try at least once or twice before you start going to these expensive adjunct therapies for which there is proof, but not great proof. So I'd probably err on the side of caution and try once or twice without doing anything like that. Having said that, if you have a lower number of embryos, like 3 or less, then yeah, I'd probably be willing to consider treatment. Whether you need to go all the way through LIT or not is between you and your RE or reproductive immunologist. And if you're seeing someone in Toronto, you're probably seeing Dr. Zaneku, my friend. So, he's great, and I trust what he says. So if he told you need a LIT, then you probably need LIT. But I would say you only need it if you've already proven that you can't carry. Remember, especially where DQ alpha is concerned, there is one study that says that it's hopeless and you basically need a surrogate. And there's another study that said that it makes absolutely no difference. So we really don't know if it's even an issue for patients or not. Certainly, clinically, we do see it in patients that have trouble, but it's a pretty low bar as far as the evidence is concerned. So we need better studies. We need more evidence. We need more information. But right now, yes, LIT is supposed to be the way to help with that. So it is something to consider. That's a tough question. Good question, but tough question.
I felt it was tough.
Tarek felt it was tough.
Hi, Dr. V and Tarek.
And Tarek. I love it when you guys include Tarek. Everybody give a big thumbs up for Tarek. Yeah.
Yeah, so I'm a patient of yours.
Oh, okay.
And I'm looking for clarification.
Okay.
I'm working to clear up a difficult case of my Urea Plasma,
okay,
which may be the cause of my recent failed transfer.
Okay.
I'm on 30-day course of antibiotics and abstaining from sex until I know it's all clear.
Okay.
If my infection is this persistent and its origin unknown, why isn't my husband also on antibiotics? I know the benefits of having sex leading up to the transfer, but I'm so scared to do that in case I get an infection again and fail another transfer.
Yeah, we don't know where the infections come from, so it is kind of hit and miss as to whether or not we treat the husbands. And the truth is, we really don't know when we should and when we shouldn't. You can't test guys for mycoplasma, urea plasma. You probably could, but you'd actually have to stick this ball-tipped Tarek shaking his head. You have to stick this thing with it's like a helical wire with a ball at the end of it, and you got to stick it through the male urethra up inside the shaft of the penis. So as you can undoubtedly acknowledge from the fact that Tarek is vigorously shaking his head no next to me, we really aren't particularly interested in having that done. So it's reasonable to get your partner treated. The truth is we don't know. So, for those who are concerned, we're happy to treat. And usually for the guys, we only need to do it for about 2 weeks. So just get in touch with your nurse and just tell her you want treatment for your husband as well, and she'll arrange it.
You said to increase the chance of a successful FET, to use letrozole to decrease the need for estrogen.
Right.
Is the goal to make you ovulate? My clinic does FET with super fat only, no ovulation, fully medicated. Can you explain why letrozole isn't superior?
It's not to make you ovulate. It's to reduce the amount of estrogen that's required. And for whatever reason, and they haven't figured it out fully, the research supports the fact that letrozole improves the success rate. And we have a video on it on our YouTube channel. It's way back, probably 2 years now. So it was a while back where we looked at letrozole, probably almost 2 years ago. And that's a really important video because that's the video that showed that it will improve your chances with a frozen embryo transfer. And there's actually several studies now that support that. They're not sure about the exact mechanism, but I would postulate that it has to do with lowering the amount of estrogen that you need. It has nothing to do with your ovulation. We don't care if you ovulate or not. In fact, we frequently will stop you from ovulating on the letrozole with cetrotide so that we can go ahead and start your progesterone. So yeah, it's not about the ovulation. It's about the effect of the letrozole on the endometrium and how it improves things. And it does. For whatever reason, it does improve your chances.
Can you suggest a vaginal probiotic?
We use one called Flora. So it works really well, and we've been very pleased with it. But I'm not really sure that there's any benefit to one versus another. So you can use any one that you want. The one we're using is from a company called NFH, which is quite well known in the fertility naturopathy world for being a very high quality product. But I don't support one product over another, guys. So that's just the one we use. Our pharmacy said that was the one that seemed to have the best mixture of bacteria in it and a very high level of lactobacillus, which is what you want. And it does seem to work. So that's the one we use, but there are no head-to-head comparisons of one probiotic versus another in the fertility world.
Hi. Please discuss TSH and FSH and how these levels can affect the FET. Thank you.
Well, your FSH really shouldn't be measured even when you're doing an FET, so it's irrelevant. Your TSH is critical. So you need your TSH less than 2.5. It's not so much for the success of the FET, although it likely has some impact there as well. It's more because of neurodevelopmental outcomes in the infant, so that if you get pregnant, you want to have those ideal thyroid levels in order to minimize the chances of any neurodevelopmental compromise. On the other side of that is the fact that when your thyroid function is lower, you tend to have less thyroid antibodies. And thyroid antibodies have positively been associated with miscarriage. So you don't want high levels of antibodies, you want very low levels of antibodies. So that's an important thing in there for you as well. And so I think that you definitely need to have your thyroid levels checked. And we really do kind of a comprehensive screening. So we don't just check your TSH, we check your TSH and your antibodies. And then if your TSH isn't right, our follow-up testing involves the T3, the T4, just to see what's going on.
Hey, Doc. Why do some clinics wait 3 cycles after failed transfer for the next FET?
I have absolutely no idea. There's no reason to do that. There is no evidence that waiting is of benefit. In fact, they've done studies that show that you can go back to back. And so there's no need to wait. So if you are normal back in your period and they can start you right away and you want to go ahead right away and your hormones are back to normal, there's no reason to wait.
I just stopped progesterone injections at 11 weeks. How can I know my body is ready to take over?
Well, at 11 weeks, you could get your progesterone levels measured, but at that point, your placenta is doing all the work already. The progesterone you've been taking is basically no longer very useful around that time. So we stop ours at 12 weeks, but even at 11 weeks, you're fine. Most places stop at 6 weeks. We continue because I don't like big shifts and changes early in the pregnancy, but you're easily able to stop at 11 weeks without any significant compromise. And there's reasonable, sort of anecdotal evidence for that. Like I said, based on the fact that most places stop after 6 weeks. Some places stop when you get your positive beta. I wouldn't do that, but you can stop earlier than 12. We just go till 12 because I'm hyper vigilant about all our patients.
Hi, Dr. V. How long does Overdrill 250 mcg take to go out of your system?
Usually around 5 days for HCG to leave your system. Most drugs will disappear within 5 half-lives, and that's around 5 to 8 days with HCG. So that's, by that point, you should be okay.
Hello, Dr. Victory.
Victory?
Victory. Hello, Dr. Victory and Tarek. I got excited that my name was mentioned. I couldn't hold it.
Premature elocution?
That's exactly it. That's right. So if we did a IUI with a trigger, and I'm on progesterone, when do we stop? Until the day of our HCG draw?
When do you stop the progesterone? You continue the progesterone until your doctor tells you to stop. So again, we continue till 12 weeks, but definitely at a minimum up until about 6. That would be what I would suggest. Yeah.
I have mild levels of increased inflammation and 5 weeks pregnant.
Okay.
How can this affect my pregnancy? What success rate do I have for a success pregnancy?
Well, you're depending on what's wrong, and I can't tell from just a kind of generalized statement like that. Hopefully nothing. You probably will sail through the pregnancy with no complications. Anytime we have anything immune related, we worry about miscarriages because the immune system can affect miscarriages. So that's where I would be worried. There's no way for me to tell you with that minimal amount of information what your chances of a successful pregnancy are, but they should be very good. If you can see a heartbeat, the chances of miscarriage drop dramatically, so you should be okay at that point. And if you're 5 weeks now, by end of this week or next week, you should be able to see a fetal heartbeat on ultrasound. So just ask for an early ultrasound.
Hi, Dr. V. Thanks for your recommendations. I convinced my RE to add Letrozole 5 milligrams to my 3 months of depot Lupron confirmed endo.
Okay.
Her office also uses Letrozole on days 1 through 5 of FET prep.
Yep.
Do I need to stop the Letrozole for a bit before resuming the 5 days as part of the FET prep? Or can I continue on Letrozole through day 5 of prep without interruption? Thanks for all you do.
Yeah, just continue it through day 5 of prep and then go. And that's what we do. We just continue our Letrozole until we're at that point where we're done. And then, we go from there. So we go past, like if you're on a 3-month Lupron shot, we would extend the Letrozole for an additional 5 days and then just roll into our cycle. So that's perfectly fine.
What would be more aggressive approach for IUI other than Letrozole?
Oh, well, more aggressive comes in stages. So you've got your oral meds, which is Letrozole or Clomid. And then you've got oral meds with shots combined together to reduce the amount of shots you need. And then you've got the shots. So when I talk about shots, we're talking about FSH or LH or combinations thereof. So things like Gonal-F, Menopur, Luveris, Puregon, Ravel. I mean, there's a long list of them, Recavel, all of these meds. So they are all available to be used. And the shots are much, much stronger than the pills are. So if you look at the studies that look at success, you're going to get a definite increase in success. But you have a huge increase in the risk of having more than one baby in there. In particular, even getting into triplets and quadruplets and stuff like that. We have no control. So you've got to be very, very cautious so you don't end up with high order multiples.
Hi, Dr. Victor. When do you recommend matrix test for an FET?
So we've now started putting the matrix test into all of our cycles just to see how well it'll work. The way we do our FETs, we're very particular about everything. So when we did an initial 20 cycles of matrix and looked back, the ones where the matrix told us not to go ahead, there was only one where we went ahead anyways. But I want to do it on a larger population. So right now we're including it in all of our cycles. But we'll see if it works. I don't want to say if you should do it or not until I know if it actually works. I think the technology is sophisticated. And I think in contrast to some of the other stuff that's out there, it's probably got a little bit more sense to it. It's certainly way better than an ERA test, but I don't want to speak to it until I know that it works. Because once upon a time, I was a firm believer in the ERA test. And for any of you that are fans of the show, you can watch any of our 4 videos or 3 videos. I've lost track now, yeah, where we very clearly indicate that the ERA test is useless. So, yeah, I don't want to jump into supporting something until I actually know that it's beneficial. So matrix technology may be great. It may be useless. I don't know. But we're definitely trialing it, and we're doing it at no cost to our patients because I don't want to make you guys pay for stuff if I don't know that it works yet.
Have you ever seen an egg mature in the lab, freeze thaw, and then become a baby, IVM?
Yeah, somebody asked that before. I saw that. So I think what this viewer is asking is, have we ever seen a case where we were able to take an immature egg, grow it in the lab and mature it, and then do ICSI, turn it into an embryo, and then freeze the embryo and use the embryo later as a frozen embryo transfer? And the answer is, I haven't, but we don't do a lot of IVM unless we're desperate. So it's rare for us that we would need to do that. So realistically, I would say that you should be okay without having to do all of that stuff with a conventional IVF cycle. If for whatever reason you're not producing mature eggs, then that's a different story. And certainly IVM is one way to achieve that. And there are definitely reports of people that have succeeded. I haven't done it in my own lab, but we haven't had a lot of people that don't have mature eggs. So usually you can get mature eggs if you try hard enough.
My BMI is 34. Does this really have a big impact on fertility?
So the question is, the BMI is 34. Does it have a big impact on fertility? Unfortunately, it does. So if you go on our website and you go to the resources tab, there's a whole section dedicated to the relationship between body mass index and fertility for both men and women. So we're not just picking on the ladies. And there is a enormous impact, both for those who are too thin and for those that are over the ideal, on your chances of success. So if your BMI is 34, it is a significant decrease in your success rates and a significant increase in complication rates. So bringing that down will definitely be helpful. Does it mean you can't get pregnant? No. But does it make it more difficult, or does it increase the risk of complications? It definitely does. So we would strongly advocate for a healthy diet, lots of exercise, additional supplements. You're going to have a lot of oxidative damage when your weight is higher. Exercise makes a big difference in success. Even just losing 5-10 pounds can significantly improve your success rate. So there is a lot of effort that needs to go into getting you ideal. And if you're not ideal, doing IUI or IVF or even natural conception can sometimes result in very bad consequences, including failure, frustration, loss of your determination, emotional problems, stress-related problems, psychological disturbances. So we want everything to be as good as it possibly can for you. And for us to help you, sometimes you have to help us help you. And that's the diet and the exercise and really focusing on what to do to get that as good as possible.
After embryo transfer in clinic, moved around straight away or lie down 20 minutes?
So we've got a video on that too. So the answer is that there is only one really good study on this, and they showed that getting up and walking around was the exact same as lying down. However, most of us believe it has more to do with your stress than it does with any actual physical benefit to moving or not moving. So we get our patients to lie down because I just think that they feel like it's a calmer experience. I know on one of the other centers that I've worked in, they just get the patient up and run them out of the room almost immediately. And it just doesn't make sense to me. So we like to keep them there, but that place is definitely super busy and they can't afford to let people stay on their bed for 15, 20 minutes. Here we have time. And if we ever get to the point where we don't have time, I'm just going to expand so that we do have time. So I never want my patients to feel rushed because that whole sensation of being rushed is going to negatively influence things, in my opinion. And so we want everybody super calm, relaxed, chill, happy. Yeah.
How long into pregnancy should one take CoQ10, when to stop or reduce?
It doesn't matter. CoQ10 has no risk or benefit in pregnancy that we know of. So it's more for your eggs than it is for the pregnancy. So if you want to stay on it, stay on it. And if you want to go off of it, go off of it. There's no changes in the pregnancy from your being on CoQ10.
I'm in week 5 of pregnancy. Having sex is harmful for me. And how many times a week?
That was a Persian lady. I remember that one. No, there is no harm to having sex, and you can have sex as often as you want, just nothing too aggressive, but there's no problem with having sex. If you want to have it every day, you can have sex every day. I don't know if I'm supposed to say that in Persian too.
I don't know. Only you would know that one.
Good. I think it'll freak out the rest of the audience if I break out into Persian. Okay, go.
Fertility menstrual blood test shows high candida. 0 symptoms. Doctor won't treat. What to do?
Switch doctors. I mean, if your doctor is not willing to treat a clear indication that there's yeast inside your uterine lining, that's not a good sign. So I would switch doctors or find another doctor or even your family doctor who will give you, like we just use 4 pills of diflucan, 1 pill per week. You need to check with the doctor though, because it is a prescription medication and it can have liver side effects. So don't use it unless you've checked with someone first to make sure it suits you and it applies to you. But that's all it is. In some places you can get diflucan over the counter. So you could in theory treat yourself if it's available to you. But again, I wouldn't recommend that because there can be side effects and you don't want to be doing something with side effects without being sure that it's okay.
My FET cycle was just canceled because of TSH of 6.
Whoa.
Do high levels correlate with poor outcome?
Yes. So there is data for that shows that if your thyroid is out of whack, your metabolism will be, and therefore you have a much lower chance with the frozen embryo transfer than you otherwise would. So you definitely need to be normal for your thyroid. You have to be euthyroid, which means under, usually most places use a level of 5. So you need to be at least under 5, but ideally for pregnancy, you want it under 2.5. So you got a long way to go. And if your thyroid's that far off, don't do it.
Low testosterone treatment, 30 years.
Is that a question?
I don't know. That's what they shared.
There must be more to that one. If you sent us the question about low testosterone treatment for 30 years, I'm not sure what the question is. So tell us what the question is and we'll answer.
It's a statement. So they're saying, this is what I got.
Well, there's got to be more to it.
So I got.
Okay.
Is it safe to do laser hair removal while TTC, doing IVF?
Yeah, it's fine while you're doing treatment. It's not fine during pregnancy because it can alter your pigments and your pigments darken when you're pregnant. So that's not a good idea. But it's fine when you're trying. There's no harm to that.
How much does BMI play into getting pregnant, carrying healthy?
Huge. So we answered that earlier. Go on our website, go to, can you do it there and show everybody how to do it? Or can I screen share off of the thingy? You can do it from there. So we're going to guide you to our website and you'll see where to go. So Tarek's going to show you the pressure. I can do it on my thing if you want on the.
Even more pressure.
So on our website, go to www.drvictory for drvictory.com. And then go to the resources tab. Under the resources tab, you'll see a thing on weight and infertility or weight and fertility, and click on that. And then at the bottom left of that page is the full PDF, or is it the bottom right? One of them's full and one of them's mini. I can't remember anymore. So there's a full download versus the partial download. So the partial download is just the abbreviated version. But if you want to look at the full download, it's there. And just pull that in and take a look at that. It's very valuable and very helpful and has loads and loads of information on where the risks are, how it affects things. It's both for men and for women. And it demonstrates very clearly where it can impact your fertility, its egg quality, sperm quality, the pregnancy, risks to the baby, risks to you, miscarriage risks, stillbirth risks, all sorts of things. And then even risks after the pregnancy, things like blood clots and maternal morbidity and mortality. So your BMI can have a very, very significant effect. And so it is important to monitor that. Now, there is data that we've reviewed on the show in yet another one of our videos where we showed that over the age of 38, it's actually more important to go ahead with your treatment than it is to focus on your BMI. But under the age of 38, then you go ahead with weight loss before you go ahead with treatment. Now, there are instances where we have to be careful. So if your body mass index is over 40, that's just dangerous no matter what. So you have to be very cautious. But aside from that, it's fine to go ahead when your body mass index is higher, but your age is also higher. So, everything needs to be individualized. We talk about that a lot on the show. If you're getting cookie cutter medicine, you're getting the wrong kind.
43 years old for FET using donor eggs. How many embryos recommended transferring?
If your donor is young, generally speaking, we only recommend one for transfer.
Is egg retrieval possible for a 36-year-old female currently menopausal with low AMH?
It's totally possible. The problem is we'll likely only get one, maximum 2 eggs, but it can be done. I just did it for a lady even younger than that who was menopausal, and she got pregnant with the first try. So yes, it's possible, and we're happy to explore that possibility with you. You just have to be realistic about the expectations. People kind of come in and think, oh, I got an egg, I'm going to get pregnant. But you got to remember that there's a very high chance the egg will be genetically not normal. So there can be failures, and that's really critical to follow.
During FET, can you take too much progesterone? Are PIO plus inserts recommended?
So PIO plus inserts are definitely recommended. We've reviewed data on that on the show. That was just, 2 months ago, 3 months ago. We have a video on that, on which progesterone is best. I don't know if you've got time to find that one. It wasn't that long ago. In any event, that we can pull up for you and show you. Bottom line is that you need both. Can you get too much? Absolutely. That's why we monitor the progesterone levels. If you get too much progesterone, you're on birth control, and that's of no value to you. So if we have too high a level, we actually cancel people sometimes. So if your level is really high, we drop your progesterone dose. And then if it stays really high, we stop because something's gone wrong and we have to use a lower dose the next time.
What steroids would be used after failed FETs, and what is the benefit of them?
Well, depending on what you read, there may be no benefit. So we use prednisone, and we use 25 milligrams. We also use methylprednisolone as part of our standard protocol, but we use prednisone to go beyond the methylprednisolone because we only use the methylprednisolone for the first 5 or 6 days. So the benefits are reducing inflammation and the activity of your immune system to give the embryo a better chance to implant. But they've done loads of studies showing that the prednisone alone doesn't do very much. So we almost never use it alone. We'll use it in combination with other agents, whether it's tacrolimus, sirolimus, heparins, IVIG, subcutaneous IG, the LIT therapy, the plaquenil. I mean, there's loads of other things that we use, but we almost never use the steroids alone because there's reasonably good research that shows that alone steroids are not beneficial.
FET what factors can affect fertility? The big one.
Well, for the next 5 hours and then the next 10 days, that's all a big question. So let's talk about the major ones because it would take me a year to go through all of them. So the major ones are going to be age, your body mass index, your social habits like smoking, drinking, drug use for both the men and the women, your egg quality, your general health. Do you have inflammatory conditions, especially autoimmune conditions, Crohn's, arthritis, lupus, stuff like that? And then you're definitely going to have to look at things like genetics as well. Those are like the big umbrella blanket kind of statement categories. The biggest factor by far being age for women. So there are a lot of different things that can impact your fertility. We have a video that is called "What is Female Infertility?" Or female infertility. What is it? Yeah. So it's got about 18,000 views. So check out that one. You can find it on our list of popular ones on the YouTube channel. Make sure you hit like and subscribe and check that out because that has loads of information that would be useful to you on what kind of factors can contribute.
Hi, Dr. V. I had my referral consult with Dr. Fred today.
Oh, good.
He says my exact DQA match does not make me a good candidate for LIT.
Okay.
Would getting donor sperm increase my chances?
Yeah, as long as your donor doesn't have the same DQ alpha match that you do. But otherwise, yes. So if you can find a donor where they have the DQ alpha, which I've never seen before, then that would be fine. Alternatively, you can take your embryo and just put it into somebody else. So using a surrogate will get you your genetics with your partner's genetics, but switching sperm sources could, in many cases, alleviate the problem for sure.
I'm sure you've answered this a million times, but thoughts on fertility testing? Complete BS? Any circumstances where it might be worth it?
So we do the fertility testing frequently. I am happy to admit that there is not great evidence for any of the stuff that they're talking about from the infection standpoint, but we have seen it almost in every case make the difference when we've treated it. So I'm a believer, but in terms of is there data for it? No. Individual studies that show that it, each bacteria has a role? Oh, for sure. Absolutely. Is there a role for the vaginal and the uterine microbiome? Loads of studies on that. We've reviewed those here as well. The immune testing from Fertility, I mean, it's the standard immune testing you get anywhere. And depending on who you believe, the immunological testing and treatments can be either, the game changer or they can be epically useless. So I believe in them up to a point, but, it's still a field where there's a lot of controversy, a lot.
I'm 35 years old, hoping to be a single mother by choice.
Yeah, cool.
My AMH is 1.66. I have no other issues. How long should I try IUI before doing IVF if I want 2 babies?
And she's 36?
35.
35? Well, if you want 2 babies, arguably you could consider doing IVF now because when you come back for your second baby, you'd be 37, but then you'd have 35-year-old embryos. So that's an important thing to consider. But IUI at your age, up to 6 tries still has success. Beyond 6, you have no success. So we would say up to 6 tries would be reasonable. And if you're going past 6 tries, you're wasting your time. When you come back and you're 36, 37, you'd still be in that 6 try range. So you could try again another 6 times. But from an efficacy standpoint, if the cost is not a problem for you, there are benefits to doing IVF in terms of speed and expediency and all that, but I'm not telling you have to do it. I'm just saying there are benefits. So consider that.
How long is the IVF process and what is the success rate?
Oh boy. Let me answer the easier of those two questions. The process takes about 13 days on average, plus 5 or 6 days to grow your embryos. And then depending on whether you're getting a fresh embryo transfer or a frozen embryo transfer, it might go in at the end of those 5 days, or it might go in a couple of months later, like 1 or 2 months later. What is the success rate? There is no easy answer to that. You can have an IVF success rate that's abysmal if you're at a bad lab or you have bad sperm and eggs. And you can have fantastic success rates with great sperm and great eggs. So there are segments of our program where we are very close to 100%. And then there are other segments of our program where you can't get anywhere close to that kind of number. So it all depends on so many factors, the most important being the age of the woman.
What are the signs of preeclampsia at 20 weeks pregnant?
So preeclampsia almost never occurs at 20 weeks pregnant. If you've got high blood pressure at 20 weeks, it's probably just high blood pressure. But preeclampsia is defined by having protein in your urine, edema, which means swelling of fluid in your tissues, your hands, your face, your legs, and so on, and high blood pressure. So the signs are high blood pressure, edema, and having protein in your urine. If you have additional symptoms like headache, floaters, chest discomfort, shortness of breath or fluid in your lungs, pain in your right upper quadrant where your liver is kind of here. I don't know if that part of me is on the screen or not, but yeah right there. Where your liver is. Yeah. So if you have any of those, you got to go right to the hospital right away. That's dangerous. But preeclampsia doesn't normally occur that early. If it's really early, you're seeing it at like 26, 28 weeks. And those are like the extreme cases. Typically, we don't see it that early. So unless you're a very high risk individual, at 20 weeks, it's probably chronic hypertension and it's being unmasked by the pregnancy. So that has treatments.
Do you look for uterine lining complications before an FET? And is it worth transferring if compaction doesn't occur, but lining looks good and thick?
We do look for it before. That's why we do our saline infusion sonohystogram. I would argue that any program that does not do the testing beforehand is probably not doing the optimal therapy. You really have to do those tests to make sure the lining is fine before you put in an embryo. If you have a polyp, if you have a fibroid, if there's anything wrong with the shape of the uterus, it can very significantly negatively impact both the chances of getting pregnant and the chances of staying pregnant. So we always check for all of our patients with regards to, what was the second part again?
Lining.
No, there was that part and then there was another part. Do I always check and?
Anything you can add, estradiol levels should have during FET, or does lining matter? Oh, sorry.
No, I was
transferring if complicated doesn't occur, but lining looks good and thick.
Yeah, no, we always check it first, and then we check your lining really carefully. So you have to have a check of the lining. It doesn't make any sense not to.
What estradiol level should you have during an FET, or does only lining matter?
We don't pay too much attention to the minimum of your estrogen, although we did review a study not too long ago that said it had to be a minimum of 100, I think it was picograms per milliliter or something like that. But it was the American units, which is not what we use. But in any event, we focus more on making sure the estrogen level doesn't go too high. So you don't want a really high estrogen level, but a low estrogen level is probably okay. The lining is more important than the estrogen level is, for sure.
Protocol for fresh transfer, anything that can help or anything you add?
Vitamins, melatonin, your vitamin D, your omega-3 fatty acids, your melatonin, all of those will be helpful. Don't do it if your estrogen level was sky high during your cycle. It won't work. Make sure you're doing the double progesterone, so the vaginal and the shots. That's pretty much it. We, generally speaking, favor frozen embryo transfers. There are cases where a fresh embryo transfer makes sense, and we support that, but the majority of people need a frozen. So the only time we kind of support a fresh approach is if you have a very low number of embryos.
Is it true that if I have a blocked fallopian tube that I will only ovulate every other month?
No, you'll ovulate every month. You may only be able to pick up the egg from the other side every other month, although one fallopian tube can actually pick up eggs from both sides. So you're definitely going to continue ovulating every month. If you're getting a regular period, you're probably ovulating every month. Is there like another gajillion questions tonight?
I don't know what's going on, but yeah, something along those terms.
All right.
Follow-up.
Yeah.
If we would like to switch from Letrozole to the shots, do we just call your office or do we need to make an appointment with you?
No, you can talk to the nurses about that. So if there's anybody out there that's with any fertility center, including ours, and you tried pills and you want to try shots, you just call the office and we'll set that up for you. We just have to be cautious while we do it, but as long as we're cautious, it's fine.
Got COVID. Now, 14 days, I feel better. Can I start Clomid and Gonal F, IUI, or wait a few more weeks?
You can start. The question is, did your partner get COVID? Because his sperm will take a turn for the worse for a little while. So if he got COVID, you might want to wait or at least get him checked before you start your meds. But if he didn't get COVID, then yeah, there's no reason why you can't try. I'd probably give it a month just to give your immune system a chance to recover. But beyond that, you'd be fine.
Please talk about melatonin.
We got a video on melatonin. Where is the melatonin video? What's that one called? I don't remember. I'll look it up. So we have a video on melatonin. Melatonin has been proven to increase your chances of success. So you should use melatonin. For sure, you should use melatonin. So especially if you're doing it with a frozen embryo transfer, then it works great. How do you search my channel? You know what? I've never done that before. Can we search within ours? Yes, we can. Look at that. Melatonin. It's called Melatonin and Fertility. It was 1 year ago. It's got a really, really close-up face shot of me, and it says melatonin. Wow. So watch that video. Only 2.2 thousand people. That's kind of interesting. You know what? More people should watch that video because that video would help a lot of people get pregnant. So it's on YouTube. Go to our YouTube channel, subscribe for Dr. Victory, and then jump into the search bar and type in the word melatonin. It's the first one that pops up. And then there's a whole bunch of other good ones.
Dr. Victory,
yeah.
What should my progesterone levels be between the day before transfer? Do we always need pessaries if levels are naturally ideal?
40 to 100? No, I mean, arguably, if your levels are between 40 to 100, you don't need to take pessaries or vaginal suppositories. But yeah, 40 to 100 is what you're looking for. However, keep in mind that the vaginal progesterone is being used to give the direct effect into the uterus, which is not measured by just what's in your bloodstream. So the reason people believe in using a vaginal and an injectable is because the injectable is doing what progesterone does when it gets into your bloodstream, but the vaginal is doing the paracrine effect of progesterone, which is that it leaves the ovary and goes kind of right into the uterus through the fallopian tube blood supply or the utero-ovarian blood supply. So that's really important because that's a much more rapid effect. You're not going to get that by just having the right progesterone level in your blood. That's why we use the vaginal. It's to get some of that progesterone right into the uterus. So we would advocate always for using both. If it's a cost thing for you and you're monitoring your levels, you don't have to. But if you can afford it or you've got insurance covered, definitely do both.
Women who are having babies at 43 and 44 with own eggs, are they just super fertile / lucky, or have they had a lot of IVF cycle retrievals?
Well, they fall into 3 categories, 2 of which you nailed. One are the ones that are just lucky and they're getting pregnant. 2 are the ones that are much more fertile than the average 43-year-old, because the average 43-year-old is not very fertile. And 3, they've either done fertility therapy like IVF, or they're using donor eggs. So when you hear a Hollywood star got pregnant at 48 or 49 or 50, those are almost 100% of the time donor eggs, unless they froze their eggs when they were younger. But otherwise, it's all donor eggs. Same thing when you hear those stories about the 60-year-old in India that, got pregnant. They're never her eggs. They're always from a donor.
Dr. Victory, do you have any vitamin recommendations to help increase success for a natural conception, specifically for men? Thank you.
Oh, for men? Yeah, we use Pro-Fertile and we use Fertile Pro. But there's a lot. There's Fertile Aid. There's one from Pacific Coast, I think it's called. There's loads. So if you're buying one that's like a bundled package with everything kind of in it already, those are all good options. And again, I don't support one product over another. I'm just throwing out names you guys can look up. But if you're doing individual ones, we'd probably be here half an hour while I list them all off to you. But coenzyme Q10, zinc, magnesium, vitamin C, D, E, a little bit of vitamin A, lycopene, L-arginine, L-carnitine. I think I said CQ10 already. All of those are pretty important. Folic acid is important. So there's a high number of these vitamins that can be beneficial for guys to take. So I would definitely recommend you get them on as many of those as you can. It's actually controversial if you look at the literature as to whether or not it helps. There are studies that show it's beneficial, and there are studies that show that they're not. So I believe in them, and we've seen positive benefits, but it doesn't work for everybody.
Hi, Dr. Victory. Are the ORs opening up to non-emergent procedures?
Yes, apparently I heard that today from one of my colleagues. I haven't heard it formally yet. So supposedly it is going to happen. Hopefully most of you have heard that we're going to be moving some of the procedures into our office because we're sick of waiting for the ORs. So
why do some clinics add progesterone after otherwise a quote-unquote natural FET and others don't? If you had multiple failed transfers, would you add progesterone after?
Well, I would not add progesterone after, because I would never do any transfer without progesterone. There's more than enough evidence out there to demonstrate that even in a natural cycle, you need extra progesterone. So we always use progesterone when we're doing our cycles. And like I said earlier in the show, we use both vaginal and the progesterone in oil. So we would never get to the point where we would be adding it, because we always do it. I'm not against natural cycles, but for us, a natural cycle still includes giving people progesterone. And so, yes, I would definitely be adding it if you've unfortunately had some failures. That's not good. And I would definitely want you having enough progesterone on board.
Is it difficult to get pregnant or remain pregnant if you are diagnosed with CAH?
Congenital adrenal hyperplasia. It's a bit tougher, but it's not impossible. We have loads of success with those patients, and it's not harder to stay pregnant as long as you follow all the medications you need to be on.
Do you do FETs in the cycles following IVF egg retrieval?
We do if your hormones have returned to normal. So if you're a super egg producer, no, we'd probably give you another month, because your hormones are still out of whack. Your ovaries are still enlarged. You're tender, you're sore. You probably just had the worst period ever, that kind of thing. But if you didn't make a ton, you made like 5 or 6 eggs, we definitely can accommodate that the next month.
Is the Unexplained Infertility presentation that you posted earlier this week for a future YouTube video? Super interested in learning more. I'm wondering if it's right, I guess.
It's going to be part of a fertility conference that's coming up on the 5th of February. And we can post some ads for that coming up to promote it. And then I'm not sure if I'm allowed to post it, but I'm sure I can. So yeah, we'll probably post it to our YouTube channel right after that. It'll be a really good presentation. So I'm trying to figure out how to do something in my PowerPoint presentation that isn't working. But I'm going to get this guy to help me out, hopefully. So yeah.
Do you recommend redoing all fertility testing when a couple comes to you after multiple IVF failures with their former RE?
Not necessarily. I mean, it depends on what was done. It depends on who did it and where they did it. So sometimes yes, sometimes no. Sometimes we just jump into new tests that other people haven't done or thought of. I would say the vast majority of the time when I see couples that have had multiple failures, I can usually figure out pretty quickly what the problem is, confirm it with some testing, and then we move forward from there. It's actually uncomfortably shocking how often I can find out that there is something that was either missed or neglected, or somebody didn't pick up on, and with a little tweak we get people pregnant. So we do this a lot with patients from the UK, Australia. Loads of times we see patients that are from the UK or Australia, and we're able to help them like this.
What do you recommend as a starting point for testing after multiple early losses? Previously had one healthy live birth and now 3 losses in the last 1.5 years.
So if you have a recurrent pregnancy loss situation, there isn't really a starting point for testing. It's just kind of like do everything. So hormones, natural cycle monitoring, saline infusion sonohystogram, your STD screen. You should have a full thyroid panel. Vitamin D levels need to be checked. Genetics, thrombophilia screen, although that's controversial. And then we advocate for doing the Fertility immune testing and the infectious testing, because I do think it plays a role. So all of those things are the tests that we start with. For the guys, you need to do their basic blood work, STD screen, genetics, and then you need to do a basic sperm test, and then they need a sperm DNA fragmentation assay. So that's like the entry level approach to all things with recurrent pregnancy loss. It's not a simple test. Like there isn't like a basic version. You either do it all, or you're still going to be scratching your head wondering, did I get all the right answers that I needed? And I'm not really into making people do tests and then wait and then get more tests and then wait, because then they just get agitated that you're making them wait so long. So I offer all the testing up front. Now, unfortunately, a lot of those tests are expensive, and I hate that, but it's out of my hands because I have no control over the cost of those tests, because it's not stuff we're testing you for. So in those situations, you have to make financial decisions, and my heart goes out to everybody who has to make those decisions. But unfortunately, they're part of the process. And if I could make it better for you, I would. I literally don't have a way. The lab does the thrombophilia screen. It's usually $700. And DNA fragmentation we do, but that's only $200. And then the fertility testing is expensive. I did make them reduce the price for our patients. So if I've done a consult with you, then you can get a discount from Fertility, but it's still expensive even after the discount.
Do you do a antihistamine protocol for IVF? Do you find it adds to the success?
I don't, because we've done it a couple of times and it didn't seem to do anything. I've looked it up and there's zero research that supports the use. So we don't do it. But that doesn't mean somebody won't come out with a study at some point that shows that it's useful. But I haven't seen anything yet. And because of that, I haven't been pursuing that.
Are aspartame and other artificial sweeteners bad for fertility?
Yeah, they probably are. Aspartame is just bad, period. So stay away from aspartame. Drink water, guys, or flavored water with some orange or strawberry or whatever you want to put in there. But or get some Perrier, but don't drink aspartame or pop for that matter.
Hi, Dr. V and Tarek.
Again, we got 3 Tareks tonight.
I feel like I should answer this.
Yeah. Yeah, careful not to inflate his head too much, because now he wants to answer the questions.
I was only given 10 milligrams of prednisone for 4 days after FET. Should I ask my doctor to put me on it longer? I was on a autoimmune protocol. Thanks.
Well, if you're on an immune protocol, you should definitely be on a higher dose for a longer time. So we would say minimum 12 weeks, 25 milligrams a day. Would you have? Is that what you would have said?
No. This one I didn't know. This is a very unique question.
There you go. Next time we're gonna like do a cardboard cutout of my face, and we're just gonna stick it on you and put you here. Yeah, although I won't have a clue what I'm doing on that side.
Oh, this is a common question today. Do you recommend LIT for a couple for a complete HLA-DQ match? One doctor told me yes, and another said they wouldn't recommend until you have failed a few FETs. Isn't it better to do lit just in case?
I think that was the earlier question. So we answered your question early in the show. I think it was one of our first ones, but the answer is if you've never done an embryo transfer before, I think, and you have a lot of embryos, then I would go ahead and do 1 or 2 transfers. If you don't have a lot of embryos, sure, I would do the lit therapy. Yeah. Keep in mind that's based on very controversial evidence for DQ alpha mismatch.
40, 6 embryos, 2 high mosaic, 1 low, 1 inconclusive, 2 abnormal. Would you suggest a second retrieval or implant transfer?
So there's 1 unproven, 1 low-level mosaic, 2 abnormal, and 2 high-level mosaic, right?
Yeah.
Ooh. I would make more embryos. The recommendations are that if you only have mosaic embryos, you go ahead and make new ones. If you can't afford to, that's a different story. But if you can afford to make more embryos, the recommendations are that you make more embryos. So we would definitely encourage you to do so because those recommendations make sense. You have 1 untested, which could be whatever. You have 1 low-level mosaic, which has a 50-50 chance. So, and again, it may depend on whether it's the whole chromosome or it's segmental. So I would advocate for trying to make at least some normal embryos and then use the mosaic only if you have to, or the unknown only if you have to.
What is the matrix test? I've never heard of that.
So matrix is a technology where we have to take a very specific image after we've been trained and accredited with an ultrasound that meets their criteria for picture quality. And it's done after several days of progesterone. And then they will tell you if the lining is good enough to succeed. And they give you a ranking system. So if you're 0 to 4, you're never going to make it. If you're 5 or 6, you're in the gray zone where they don't recommend it, but it might be okay. And if you're 7, 8, 9, 10, you're golden. So interestingly, with our protocol, almost all of our patients are above 7. And so we were really excited about that because it meant our protocol was working exceptionally well, which is probably why our success rates are so high. But there was one discordant one where we thought the lining looked great, but Matrix said it wasn't. She actually did get pregnant. So I'm still not sure if Matrix works or not. But in any event, we're trialing it out for a bunch of our patients. So we'll see.
Why are progesterone levels said to be so volatile? And that being the case, how can we use results of progesterone tests? What problems can excessive levels of progesterone cause? Thank you.
So progesterone levels can be volatile depending on your absorption, how you're taking it. Is it vaginal? Is it injectable? Did you inject it in the right place? Did you hit a vein or an artery when you put it in? That kind of thing. It can depend on the testing that's used because some tests for progesterone are notoriously inaccurate. And it depends on when you do your test, like in relation to when you took your dose of progesterone. So there's a lot of factors that go into the volatility of the levels. As far as can you take too much, you can absolutely take too much. If you're on a very high dose of progesterone, you're on birth control. That's not a good plan.
Oh, off topic.
Off topic. Uh-oh.
How old are you, Dr. B?
Oh.
You look amazingly young.
I am amazingly young. That's the answer to that question.
Hey, Dr. V. I
Yeah.
had the Emma and Alice test and found the E. coli is higher by 0.02 than the normal range. My doctor canceled my FET and put me on antibiotics and probiotics. Does E. coli affect transfer?
Almost certainly yes. Again, we don't have strong evidence for this stuff, but almost certainly yes.
What would be some reasons you would have a 3-week period?
Polyp, fibroid, hormonal abnormality, ovarian cyst, failed pregnancy, retained tissue, infection, COVID vaccination. think I just ran, thyroid abnormality. I think that's most of them.
What would be more aggressive method of IUI except for Letrozole and Overdrill?
We did that one basically, but shots are more aggressive than pills.
Any updates on the Sarnia Clinic getting funding for IVF from the government?
Not yet. Still waiting. Should be any day now, but I will refrain from saying anything negative about our wonderful government because I'm hoping they give us funding. So I will hold back anything negative until I see if they gave us funding. If they did, I will love them eternally. If they did not, then we'll figure out what to say and what to do. Yeah.
Which is best, oral or vaginal probiotics?
Vaginal. Yeah, definitely vaginal. Oral is not going to get into the uterus. You need to take it vaginally to get it into the uterus.
Thank you, Tarek.
Thank you, Tarek. Oh, boom. Yeah, that's not okay, people.
You answered my question from install. We'll send you a thank you note. This is so helpful.
Oh, cool. You have no idea what that's about, do you?
You answered my question.
Oh, terrific. All right.
Yeah.
Thank you, Tarek.
Hey, wow. I pick them. Have you ever actually seen an egg mature in the lab? Oh, they're hopping, these guys.
I know people ask the same question over and over again. Yes, I have seen eggs mature in the lab, and there are reports of that working. It's called IVM. But we try and avoid it here because the original premise of IVM was for patients with PCOS. They didn't want them to hyperstimulate, so they'd retrieve all their eggs very early and then mature them in the lab and then do, the IVF procedure on them and see what they got. These days, with the protocols we use, we can get 50 eggs out of people and they still won't hyperstim. So there's absolutely zero indication for doing IVM in those cases.
Hey, Dr. V, what can a high cortisol level 648?
We talked about
this one.
Yeah.
Yeah. Okay.
Is it kind of like a rehash of all the original ones? Or it's recycling somehow?
People miss their questions.
If you guys have asked questions, almost always we answer most of them, if not all of them. So make sure you're there at the start of the show because we're answering your questions at the start of the show often, especially if you asked in advance.
Dr. V and Tarek.
903,
Thanks
dude.
for your time and patience in hosting this show. Really appreciate the love and information here.
Ah,
That's good.
That's good. Anything left?
Like
a gajillion or?
I wouldn't say a gajillion.
Dude, you're scrolling at 100 miles.
Yeah, I know. That's why I said I wouldn't say a gajillion. I'm trying to give you a number here. What's the Fertility Assist immune test?
Yeah, they have immune testing of a bunch of different things. T helper cell levels, Th1, Th2, complement levels. They've got the DQ alpha stuff. There's a whole bunch of things that goes into their immune testing. NK cell activity.
Hi, 29 with DOR, AMH4. A few months later, up to 6. 6 months later, another us and 12 plus sub-CM follicles.
Oh, good.
Each ovary demonstrating PCO appearance. FS said no concerns. Thoughts? Thank you.
I need to know if your AMH is in nanograms or picomoles because your antral follicle count does not jive with your AMH. And so I would actually suggest that you get checked out because your AMH was quite low. I would need to know why your AMH was so low. It's possible it was because you were suppressed from something, birth control or stress or whatever. So that's a case where you should see an RE to make sure that they are following you and seeing what happens with your ovaries.
This guy seemed to have missed the question, so I'll just repeat it for him.
Okay.
Okay. Hi, Dr. V. What can high cortisol levels 648 nanomoles per liter and high 1708 progesterone levels of 20.1 nanomoles per liter signify? What additional testing one should do and how to lower it?
So you probably have congenital adrenal hyperplasia. That's more information than we had last time. So you probably have something called congenital adrenal hyperplasia. You need to see an endocrinologist. You're most likely going to need steroid therapy to suppress the congenital adrenal hyperplasia to bring down your 21-OHP and to bring down your cortisol levels. So once you're on the right steroids, your system will go back to normal. But definitely you need an endocrinologist or a reproductive endocrinologist. So see one of us and get the appropriate treatment, because you'll start manifesting signs of hypercortisolism and hyperandrogenism as a result of the high 17-hydroxy-P and the cortisol as well.
Would you recommend IUI for thinner uterine lining or go on to IVF? 2 prior IUI times 5.7 and 6.2 uterine lining thickness, age 36.
I'd actually recommend you figure out why your lining's thin and how to fix it. So we do have all sorts of techniques we can use. We just got the PRP machine, so that's coming shortly. There's vaginal Viagra, which works pretty well. Baby aspirin, vitamin E, pentoxifylline apparently works sometimes. There's loads of stuff you can do, GCSF or GMCSF. So there's all sorts of options. Don't do anything until they figure that out first. You might want to look for infections, that kind of thing. And then we can talk about what we need to do for you. We're done? Yeah. Okay. Wow. It's now 9:07. And Tarek has been my faithful companion for the evening. So thank you very, very, very much to all of you for watching the show. Thank you to my esteemed colleague, Tarek Ibrahim from Ibrahim Strategies Group, who always does an amazing job for us and makes me laugh every day. And thank you to Ken, my buddy, who helped me hang a 160-pound television, because we are doing so many cycles now, we couldn't keep it on the glass board we bought, the 4x8 glass board we bought. So we had to move it digital so that we can scroll through a touchscreen 75-inch television and still maintain all of our cases on one board. So super excited. Thank you for helping us grow. Thank you for watching Fertility Fact or Fiction. And as always, jump on our YouTube channel and subscribe and like and comment, and we will get back to you when we can. Have a great day, guys. Stay safe, get vaccinated, and we'll see you